Mr. Chairman, Mr. Vice Chairman, thank you for the opportunity to testify here today. My name is Scott Gottlieb. I'm a physician and resident fellow at the American Enterprise Institute. I previously worked at CMS and FDA and have experienced and evaluated the insurance market as a provider, as a policy analyst, and as an investor in the space. And it's from these three perspectives I want to offer some thoughts today. We face some continuing challenges with respect to our current insurance market and some new pressures, and I want to focus not on how we got here, but what we can do about it. Improving the existing market for insurance inside the state-based exchanges or transitioning to an entirely new framework for how we pool risk and help consumers buy coverage should include in particular four principles I want to outline today. First, more rating and regulatory flexibility for insurance products to enable more competition between different and hopefully more innovative plans. I believe that regulatory standards and how CMS is interpreting its own rules limit the ability of plans to offer innovative designs. Because health plans must adhere to a narrow formula to fall within the discrete metal tiers, it leads to an environment where plans are designed from the top down, off actuarial targets, rather than based on a bottoms-up approach to build off principles that may lead to more innovation and coverage. To these ends, insurers can be required to simply report the actuarial value of their plans so long as they meet a minimum level of coverage. Instead of making decisions based on rigid targets that are tied to metals, consumers can make choices based on the actual actuarial value of the plan. I believe allowing more regulatory flexibility around rating and plan design would enable a wider selection of high-value options, such as value-based insurance designs or designs that reduce premiums and other costs for consumers that stay with an insurer over time. Second, we need clear rules on open enrollment periods to enable a viable risk pool while using incentives rather than mandates as a way to keep people in the insurance market. We absolutely must maintain some exemptions for people who confront some discrete challenges obtaining coverage during open enrollment periods. But carefully defined enrollment windows can form a key element of rules that use incentives to encourage people to enter the insurance market and stay continuously insured rather than relying on penalties to enable these same outcomes. Right now, the lack of tightly defined enrollment periods, verification requirements, and fluid exemptions largely forecloses the ability to use a requirement for continuous coverage as a way to create incentives for people to get into and stay in the insurance market. Third, subsidies need to be tied more closely to risk, and risk adjustment must provide plans with incentives to enroll and improve the health of people with chronic conditions. In the plan that I helped co-author at AEI with my colleagues, we advocate a system of tax credits. These are set initially as a fixed dollar amount based on age. Under our framework, older individuals would get larger subsidies reflecting the tendency to use more healthcare services. Another option is to match the magnitude of the tax credits more closely to the varying insurance costs that real purchasers will face in a less regulated market. This second option would make the tax credit amounts more open-ended initially and responsive to premiums that may vary with age, geography, and perhaps some form of pre-existing risk. This initial floating cost subsidy structure could then be adjusted in later years to set a ceiling on maximum tax benefits to curb overspending and add additional subsidies for more economically or medically vulnerable populations. Any approach should be coupled to proper risk adjustment so that health plans have an incentive to enroll individuals with certain pre-existing conditions and improve their health. The credit that health plans receive can be adjusted prospectively based on a defined set of healthcare conditions and a methodology that the insurers agree to in advance, since they're the ones who know best where the economic sensitivities are. Fourth and finally, we need to contemplate policies that offer incentives for new plan formation and alternatives to the hospital-led consolidation of providers that are driving up costs. With respect to health plans, there's been no new net health plan formation since 2008, and by this I mean new health carriers. I believe that a big culprit is the caps on the operating margins, which makes it hard for new plans to enter the market, even with some of the concessions that are made available to startup plans. On the provider side, we need to consider policies to create alternatives to the consolidation of physicians around local hospitals, which is increasing in a number of markets and is giving a single health system this sort of monopoly position that's driving up costs. Our healthcare reform should be aimed at increasing choice and competition as a way to give consumers more options and more opportunities to access affordable coverage. I hope that these concepts I outlined here today can advance some of these goals, and I'm grateful for the opportunity to testify before the committee. Thanks a lot.